as it pertains to immune therapy for metastatic non-small cell lung cancer. So maybe if it's okay, actually, we'll get started then.
Sounds
Okay,
good.
perfect. Okay, great. Well, firstly, thank you everyone for joining today. We'll be presenting about immune therapy in metastatic non-small cell lung cancer. We really have an esteemed panel here with Dr. Edward Garon from UCLA, as well as Dr. Borghaei from the Fox Chase Cancer Center, who really have led and pioneered many of the regimens that we currently use, including both um, original studies with nivolumab, CTLA-4 in combination, and pembrolizumab. Really kind of going back in historical review with how these medicines actually came about, the large studies that led to the approval originally in second line metastatic non-small cell lung cancer, and then ultimately now in the first line. So what we'll do is that we'll kind of go through a little bit of a journey talking about the landscape and such, but please do let us know if there are questions. And also, Eddie and Haas, at different points, there'll be kind of junctures where it'll be great to kind of, just understand practice, nuance, and where kind of additional data can be generated. At the end, actually, we do speak a little bit about, just some emerging concepts post the first line and as it pertains to immune therapy. It'd be great to kind of get your thoughts on those too. So again, this is just a pretty, overarching slide, which demonstrates how some of the traditional strategy is in first line non-small cell lung cancer. I think what's curious about this is that obviously genomic testing is a main component of the first application of how we better understand how to proceed in the first line. And then when certain first line genomic drivers are negative, ultimately how PDL1 helps us stratify patients. We'll actually just take a pause and reach out to Dr. Garon and Dr. Borghaei here. So, originally this slide, was created, I think in 2021 or 2022. And now it's 2 years later. And I will say, and actually just as a reflection point, how have you seen this adapt? Is there anything that you feel in the first line deserves kind of some new attention based on, where we've been over the last, couple of years? Anything kind of that you're aware of or kind of thinking about relative to, and we're going to go into a deeper dive about PD1, CTLA-4 plus PD1, but just as a general principle, anything that you think we should keep our finger on the pulse with here?
From my perspective, I think there are some technical details that I think that this slide probably was created before the Poseidon data came out, which for completeness sake, if you were to make this slide today, it would have the Poseidon data. However, I would argue that that's not a conceptual advance, for instance, over 9LA. I might argue it's a little disappointing, but there isn't anything that's made this look silly over the intervening few years. I don't know, Hasa or
Yeah,
Mateen, if you have different ideas.
no, I was exactly thinking the same thing. If we make the slide now, we include Durva-Tremi just to be fair, balanced, and sort of complete. But, I don't really think there's been anything practice changing. And I absolutely agree with you, Eddie. I think it has been rather disappointing not to have made any improvements. We definitely have hit a plateau when it comes to the role of IO in the front line. So, yeah, I agree with your comments.
You're really, really astute, and thank you, both Eddie and Haas actually for that. Speaking about Poseidon, actually, one of the premises, and there's currently a prospective study called the Triton study,
Yeah.
looking at the Poseidon regimen in a biomarker selected patient population with STK11, KRAS and such. My question then is that do you feel like the list of oncogenic drivers here should be adapted? And should we include some of those markers? What do you think about STK11? We're going to go through this a little bit more,
Mhm.
but now do you feel like if you were to recreate this slide at this point, obviously HER2 needs to be added here, but would you add things like STK11 to this?
Yeah, again, if you're talking about something that should be widely available and people should be paying attention to, I would say no, in the absence of a prospectively designed randomized study, which hopefully Triton will provide. I think if you're thinking about should we consider STK11 and KEAP1 when we're deciding how to treat a patient based on retrospective data, I think, in my view, there's multiple set of retrospective data suggesting at least KEAP1, or particularly KEAP1, I should say, just not responsive to single agent IO, even when combined with chemo, really doesn't have that much of an activity. So it's a consideration, but it's not something that's going to make it to the guidelines anytime soon. And it is not something that I would go out and say everybody should pay attention to and change treatment based on retrospective data. So in a way, I guess my straightforward answer to your question would be no. Maybe I would have a separate bracket and say, give some consideration to a CTLA-4 combination if you see a KEAP1 or STK11. But I would also admit that there's absolutely no prospectively designed randomized trial to truly show role of CTLA-4 antibody in that setting.
Thank you.
I don't know what Eddie thinks.
Yeah, I mean, I think the one thing that's interesting for me, and Has, are you on the Triton study committee, the steering committee as well? I think, right.
Yeah.
So it's an interesting study in that I find myself to be highly enthusiastic about this study because, in many respects, I'm just sick of the idea that I have people from the pharmaceutical company one direction or the other trying to convince me to use one regimen or the other based on these sort of retrospective data sets when we've sort of poo-pooed that sort of approach historically. And what I've always wanted was to have something that is a direct comparison so that I don't have to do that and actually can use valid data. That being said, every time there's a spot that opens up to move this to the top of the list for studies that are going to accrue at my institution, I'm having trouble pulling the trigger to make this the one that I push ahead. And I think part of the issue, and I don't know if Ha sees it differently, I think that it is possible that there will be a superiority of one of these. But I also don't think that we're going to get to the end of this and say, we cracked the case, that now we know these people now do great on this. And I think that has been a little bit of the thing that's probably discouraging me a little on this.
Yeah, I mean, I have some reservations about the study, even though on the steering committee and all of that also. But I think at the end of the day is our best effort to sort of in a prospective manner try to answer this question. So I think from that point of view, I actually give AZ a lot of credit for sort of going based on the data they've generated from the Poseidon. Again, retrospectively, they look at the Poseidon data and they've said, look, it looks like, in KRAS, STK11, KEAP1, Tremi, Durva Tremi is a little a better regimen. And they're saying they're going to go with the data and they're going to generate the prospective trial. And that's a gutsy move. And I think I give them a lot of credit for putting the study together. Now, is the study powered enough to answer all of the questions? I don't know. It's a kind of a smaller trial. Is tremelimumab the best CTLA-4 to use in this setting? Is there a role for continuation of CTLA-4 inhibition? Because maybe that's what we need for that particular target, and maybe just 4 or 5 doses isn't going to be enough. So there are a lot of questions in my mind regarding all of that, but I agree with you that again, I think this is a study that I am excited about, and I'm going to try to open it at my center just so that we can generate some data and answer the question.
Well, thank you both. Actually, I have to say, it's such an enlightening experience speaking with you both because it really kind of, we absorb and kind of reflect all of these considerations that ultimately lead to the large trials that we kind of see and reported and such. So with that, actually, I think we'll move on to, just some considerations. And this is more of just kind of an educational point around, the fact that that schema that was originally created really still holds weight around kind of prioritizing how we think through some of the biomarkers, particularly the NGS. This is from the original immunotarget study. There's been subsequent, in several different reports actually showing how different oncogenic drivers perform differently when exposed to PD-1. And what we can see is that, the type of driver can be important. Those drivers, such as EGFR, ELF, ROS, generally have less tumor mutation burden and have underperformed in the context of a PD-1 inhibitor. That being said, actually, there are some drivers that have been correlated with immune response. And in fact, some of the patients that I've had now who have been my longest survivors on a PD-1 monotherapy have been those with KRAS G12C. And it will actually just take a moment, Husain, you know, um, it'd be great to ask you a little bit about how you see this first line shaping in the KRAS space or in kind of some of these drivers. Do you see that ultimately there is an approach that'll be viable here for G12C plus PD-1 and kind of how do you think about that concept as a whole?
Well, I I kind of think what we do in lung cancer is that if something works okay in the second line setting or third line setting, we sort of want to bring it to the front line setting, as though there is a mandate that that has to happen. Now, there is historical reasons to think if something works well in the refractory setting, in a frontline setting, the activity could be better, particularly with targeted therapy. So I think the concept of taking something that has 30% response rate in a second, third line setting and move it to the front line, hoping that the activity would go up is, it's not a bad idea, but it doesn't mean necessarily it's going to work. The problem is that in the frontline space, as we have just talked about, the chemo IO, regardless of how you do the IO, is a dominating force, and it is a very high bar to beat. So the best approach taken by many different people, different groups of investigators, seems to be to just combine something with chemo IO and make it a quadruple therapy or some to that effect, and hope that the activity would be good, the durability would be good, and all that. So we're seeing, and again, I'm not sure that's the correct strategy. So I think that G12C inhibitors will eventually make it to the frontline space. But I think we're beginning to see a lot of variability in the tolerability of these drugs and the ability to combine them with checkpoint inhibitors from drug to drug. That probably has something to do with just the chemistry of some of these drugs. It's an evolving field. As you know, there are several other G12C inhibitors, and the word on the street is that one of them is much better than the other ones we have right now, although we don't have any randomized studies or head-to-head comparisons. It's like cross-trial comparisons. So there's a lot that needs to be determined. Now, the one that you're showing here, but the sotorasib plus checkpoint inhibitor, we sort of have decided that that combination might be a little bit too toxic given the liver toxicities that's seen with a couple of different checkpoint inhibitors. But I do believe some of the other G12C inhibitors will eventually be moving up front to be combined with at least IO. The strategy of maybe combining this with chemotherapy is another one that I've seen sort of developed over the years. But again, I think that the bar is a little bit high when it comes to the chemo IO, and one has to wonder whether just dropping IO and going with chemo for a specific patient population makes a lot of sense. Yeah, now you're showing Crystal-7, and that actually, at least based on the number of patients that they had on the study, seems to suggest that the other drug, adagrasib, can be combined with a checkpoint inhibitor. You still do have liver toxicities to worry about, or perhaps not the significant grade 3-4. So if you watch patients very, very closely and intervene when the liver numbers start going up, and then maybe you can rescue these patients and not have a lot of significant toxicity. So the real question is this 60% response rate something that's going to be maintained when you go to a randomized phase 3 trial? And then are we really going to have improvement in PFS and OS above and beyond single agent single agent IO, I should say. And that's something that, remains to be seen. I would say probably PFS improvement is probably going to be a little bit better. The OS advantage, yeah, I'm not 100% sure we're going to see it, but again, I think that's the experiment that needs to be done.
Thank you, Haas. Actually, that was super insightful and comprehensive. Actually, here, Eddie, any thoughts in
I
addition to
think
what Haas said?
the one thing, and as Haas mentions, there are now these studies that are looking at combining with chemo. These are being looked at particularly in patients who have lower PD-L1. I think it's important to recognize the potential costs of an approach like this, and I'm not talking financial costs alone. These are sort of, this is the one drug where I have patients, this being the or one drug class, the PD-1 inhibitors or PD-L1 inhibitors, where we were involved in some of the earliest studies, and now I have people who are a few years into their second decade after this treatment, and that's incredible. The question that I think comes up is, do we think a KRAS G12C is going to increase the number of those people? If it does, then we're obviously going to be extraordinarily excited about it. I think the thing we have to remember is that if you do run into toxicity concerns and have to stop a PD-1 or PD-L1 inhibitor, the question becomes, are you going to risk the idea that some of these people who are now well over a decade into their therapy wouldn't have gotten to that point? And I think that that it makes sense to certainly do these studies, but I think the enthusiasm is a little less there until I start to see some data, as what Haas mentioned, seeing something about these long-term outcomes. This isn't something where I'm going to be wowed by a response rate. We know that KRAS G12C inhibitors work, and we know that PD-1 inhibitors work. Are there going to be a bunch of people living for a really long time because of this approach? And I think that would really excite us. But I think that's what ideally we would see to get us at least excited about it.
Super insightful. Actually, I think that's really important point to reflect upon. So now kind of, just going into some of the regimens, and again, not all the regimens are here, so disclaimer there, but the ones that are here, kind of this is showing some of the chemo combinations and, dual approaches, dual IO approaches. Here actually just shows some trial designs, some keynotes, some key points are that Checkmate 9LA, 2 cycles of chemo, Poseidon 4 cycles of chemo, the Empower Lung 3 combined both squam and non-squam, Checkmate 227, Ipi-Nivo, and again, the Keynote 189 and 407 divided the squamous patients populations. So here, this is kind of an interesting way to look at it as well, which is kind of the rates of AEs per regimen. And I think some interesting points is the dual IO approach does increase rates of grade 3 or higher immune-related AEs. Interestingly, Poseidon did have a little bit lower rate, so that was just one point to note there. But here represented are the grade 3 or higher, the treatment discontinuation rates. And it is curious, actually, that, the discontinuation rates seem quite low with the dual IO approach, relative to some others. And any comments, Eddie and Haas, about kind of looking at it from like a safety perspective here?
So I think one of the things that I'll just mention that I think particularly you have to take into account when you are doing these cross-trial comparisons, we always caution against them, of course, but then we have nothing else to do because they're not compared directly to each other. The one thing, though, that you have to sort of evaluate is there a reason to think that the populations between these studies could be significantly different? My personal concern on this always has been that in the dual IO therapy, that it is likely to be a more robust patient population. There absolutely are patients that I enrolled, for instance, on Keynote 001, that I would never have enrolled on Checkmate 227, because I would have been concerned about their ability to tolerate it. And we did. We had 90-year-olds for sure on on those studies, and people at least into their late 80s. And I would have been concerned about some of those people on this study. So I think when you look at some of these numbers, particularly not maybe as much as response rate, maybe that factors a little bit, but things like treatment discontinuation rate, I think there in particular, you have to recognize that these are not exactly the same patients from one study to the next.
Yeah, again, it would be good to superimpose something about age, and what percentage of patients were over the age of 70 or 75 in all of these studies, and sort of see if there's any kind of correlation with the additional toxicities. Look, I don't think anybody denies that dual IO is more toxic. I mean, there's something about CTLA-4 that just makes it a little bit more problematic. At least in my view. I blame a lot of the side effects of ipi-nivo when I use it on epi, rightfully or not. So maybe the Poseidon is a little bit better because it limits the amount of CTLA-4 that you get. But then again, I go back to what I said in the beginning. Maybe for CTLA-4, we actually need a little bit more of a continuous suppression every now and then, just to have the full effect. I don't know for sure. But yeah, I mean, the toxicities of the regimen are unfortunately real. But balancing it versus the clinical efficacy for each patient that we see in the clinic, I think is the key. And obviously having all of these options, sort of, seeing what patient preferences are, also matters. This is not like in non-small cell lung cancer, we have the option of, all of these regimens that we can talk to patients, assess the patient, and like Eddie said, do I want to give somebody 227 or do I want to give somebody 189? And you sort of make a call and you go. It's not like in mesothelioma where we don't really have a lot of options. And, if you have a really bad acting mesothelioma, ipi-nivo is what we want to use, right? So at least here you have the possibility of adjusting the regimen to the patient that's sitting in front of you. Some of it is based on just your experience with all of these regimens. Some of it is based on clinical trials. But at the end of the day, the toxicities are real. These patients have to be watched very, very carefully.
So I may ask you actually, what is your typical patient profile for a dual IO combination or such?
Yeah.
And what is your profile for someone actually that may not choose the CTLA-4?
Yeah, good question. So almost uniformly, PD-L1 negative patients, particularly squamous cell histology, I use the 9LA regimen. I've had good success with it. In the absence of having a really attractive clinical trial, I think that has been my go-to regimen. So that is almost exclusively the patient population I concentrate on. Now, a younger, more robust patient with a KEAP1 or STK11, I would also consider 9LA, and I have that discussion with them, even though the data is retrospect. I think, again, because I think there are multiple sources pointing to the same direction, I feel a little bit more comfortable offering the 9LA to that population also. For everybody else, as long as PD-L1 is, a little bit lower than 50% is chemo IO, and for those 50, 60 and higher, I feel very comfortable with single agent IO unless, they have a significant disease burden.
Thank you. And Eddie, your thoughts actually there? Like a patient profile you would consider for CTLA-4 or not?
I must admit, it's not something that I've necessarily embraced outside of the context of a protocol. Now, one difference between my practice and Haas is in part just based on location. Jonathan Goldman, my colleague, has joked that he's more likely to see an ALK gene rearranged patient than a squamous cell. And that's probably true for us.
Yeah.
And I don't think that's probably true for you, Haas. And so one of the things that in my own practice, I'm not able to generate sort of a huge experience with squamous because we just see very little of it here in LA, at least in academic practice here in LA.
No, I agree with you. I think that's common. A lot of my colleagues or you guys tell me that in the West Coast, you have a lot more patients with molecularly driven tumors, and we definitely don't see it. Like one of your colleagues on the other side, who's not with me, Suki, says that all the time. Suki now is on our side, and she's surprised by how different the patient populations are. But that's what makes clinical practice different parts of the country so much fun. Yeah, you learn. I think we should all rotate into each other's clinics just so that we can see what happens with the other group.
That
I
would
actually
be
think that's really
interesting.
true. Yeah. Yeah, that'd be super interesting. Even in Southern California, I'm sure if we took geographies, whether Inland Empire, San Diego, West LA, Orange County, we may see some regional differences as well.
Yeah.
So I'm just going to move on and kind of, just take like a little bit of a pause to kind of just mention some of the trials. So Keynote 189, pembrolizumab plus chemo in the non-squamous population. Here was the original release of data with the overall survival hazard ratio of 0.49. We now have 5-year update, and I think some interesting points there. The median 22 months versus 10.6 months. In this tail of the curve, about 20% of people alive in the pembrolizumab arm versus 11.3. Some subgroup analysis is just showing that patients derive benefit across PDL1 status and such, without brain metastases as well. Keynote 407, again, original study in the squamous population for pembrolizumab, and hazard ratio 0.64. 5-year update, also about a 18% 5-year landmark survival. Median was 17.2 months versus 11.6 months. Here's the subgroup, also benefit across PDL1 as well. So, there's been other agents that have also emerged in the space, and the Empower Lung 3, looking at cemiplimab plus chemotherapy versus chemotherapy alone. Here shows overall survival and PFS, median OS about 22 months versus 13 months, median PFS 8.2 months versus 5 months. Subgroup analysis, did show benefit, and in this analysis, in the original study, the PDL1 less than 1%, wasn't as impressive as the other subgroups. But now with 2-year follow-up, we do see that the hazard ratio improves, particularly for the squamous patients. And really the squamous patients at that 2-year follow-up, for the PDL1 negative, really kind of driving a lot of benefit. And then we can see with the other subgroups, 1 to 49, greater than 50%, showing benefit. I put over here actually the Keynote 407 squamous study for 5-year. If you look at that 2-year point, the curves appear to kind of come together. Haas, do you make anything of this, that PD1s, like, there could be some differences here across the PD1s in the squamous histology, non-squamous histology, how we think about that?
I mean, if you just go with the data you're presenting, yeah, you got to think about this and sort of wonder if for some reason cemiplimab is better, but there really isn't, a lot of indications to sort of indicate that one checkpoint inhibitor is superior necessarily to the other. I think it has to do with what Eddie was referring to. We do have to be very, very cautious when we look at these cross-trial comparisons. I agree, 407 5-year update is kind of a disappointment. You don't really see that sustained benefit that you were hoping to see, or the ones that we see in the adenocarcinoma. I would also caution, yeah, the 2-year data looks good, but why don't we wait until we have the 5-year data and see what that curve looks like at the end of the 5-year survival curve, like we have for 407. I don't know how to explain why PD-L1 negative squames and only 54 patients have a hazard ratio 0.6 with cemiplimab, and they didn't achieve that with pembrolizumab. But it'll be hard to find a member of the thoracic community that argues pembrolizumab is not a good PD-1 inhibitor. So I think, again, this is what the data shows. This is how it comes up. I'm not necessarily sure that I will sort of start using cemiplimab exclusively in my PD-L1 negative squames based on the subgroup analysis.
Eddie, your thoughts actually on that point? Yeah, I very much agree. I think the one thing though that we sometimes in our sort of push to be fair, we try and be overly fair in that we say, oh, there's no difference in anything and you can't ever do a cross-trial comparison. Well, I think that if you were to tell me that I'm going to give Keynote 189, but I'm going to substitute out atezolizumab in my patient, I would say, no, that's not okay, because in fact, they ran that study, and for whatever reason, that study didn't hit and didn't look very similar to Keynote 189. I don't know the explanation, but it didn't. That being said, if you were able to find a point somewhere on either of these curves between two drugs like pembrolizumab and cemiplimab, which I would argue on the totality of the data look extraordinarily similar, I get very cautious about the idea of picking out one point in one study in one subgroup and saying, this is the subgroup to do this. I think that I still have some concerns about whether or not choosing squamous patients for CTLA-4 inhibition specifically is a rational subgroup for that. PD-L1 less than 1%, although I still have not been totally swayed, I am confident that that is an appropriate, biologically, I can understand why someone would say that is an appropriate subgroup to be targeting. But now you start to get me to what is the scientific argument that the epitope being hit by cemiplimab in data that otherwise is extremely similar between the two agents is particularly relevant for squamous cell when being given with chemotherapy. And I have a hard time figuring out the scientific justification for that.
Yeah, I mean, with the same argument, if you look below for the non-squamous PD-L1 negatives, the hazard ratio is 1.26. So are we suggesting that cemiplimab should not be used in non-squames in that setting? I mean, these are statistical things that happen from time to time in studies. If you do 100 different phase 3 studies with, all of these checkpoint inhibitors, you're going to get outliers, and some are going to be positive, some are going to be negative, simply because that's what the chance is, and that's what the different patient populations will bring you. So, again, based on this, should we just use cemiplimab with PD-1 negative squames? I mean, it's just the whole thing doesn't necessarily match. So it's hard for me to isolate that 50 patient subpopulation and say, aha, this is the reason I'm going to switch to this particular regimen.
A really great discussion here, on that point, because I think it helps us, just think through how we should be evaluating each study. So, just some other points. So here's Checkmate 227. Again, I think Haas, I think you were, very involved in,
yeah, and I still get a headache every time I look at the study design.
Okay, so again, stratified by PD-L1, Ipi-Nivo versus Nivo versus chemo, and then the PD-L1 negative patients, chemo, Nivo plus chemo, and Ipi-Nivo all being vetted here. So here's 5-year overall survival. Again, we can see that Ipi-Nivo, about 24% alive at 5 years, 17% with nivolumab and chemotherapy. Less than 1%, again, we can see about a 20% survival rate at 5 years, better than Nivo plus chemo. I may actually ask, now that we're seeing, these 5-year data and these 5-year data have been presented already, because you both are, kind of leaders on these studies and such, will there be another analysis? Like, will we get more data beyond this? Or, I mean, from what I'm aware of, this is like the final analysis, and we're not going to get more. But do you feel like the companies are being pushed enough to kind of give us better long-term analyses and data? Eddie, you had spoken about, some of your patients who are reaching their second decade. What is the plan or kind of around, are we going to get longer data here?
Yeah, so I might start here because I'm sort of knee deep in this right now. In that that yeah, we're certainly looking at our own data on the 10-year patients with pembrolizumab. The problem that happens, and I had no role in 227. My only role has been to criticize it. But Hans, I know, has been involved and will be able to tell us the answer to this question. But like for instance, Keynote 001, Keynote 010, Keynote 024, those studies are done. There's no the studies are completed, they're closed at all the IRBs, and they are done. They have rolled people over into protocols that allow them to get the drug, which is, I would say, admirable, rather than trying to push them onto commercial drug, which I've always thought is a little unfair way of treating the patients who led to all the benefit of a trial. That being said, the data that you collect on those patients is much less, and you also have a substantial drop off in how many people are going to be going on to that. And it makes some of the analysis quite difficult as well, because obviously one reason that people don't go on the rollover protocol is that they have died. And that's probably the most common. It is the most common reason. But there are others as well. And so once you get off of the main study, the data quality is naturally going to drop off. So, Haas, I don't know if 227 is still ongoing or if there's some similar rollover protocol.
So there is no rollover protocol, and I think there will be additional 6-7 year data presented. I guess I first of all agree with you that I like that idea of the rollover, and I think it is unfair to patients to put them on commercial drug once the drugs are approved. I absolutely agree with that comment. I think that's something that every company should, pay attention to and do what the Merck is doing with the rollover trials. Hatem, how is that going to help us if we have 10-year survival data, besides saying, okay, we still have 15% survival? Is that really going to change how you look at these drugs and these regimen necessarily? I think what I'm trying to drive is, yes, we're happy to see 24% of adenocarcinomas and 19% of squames alive at 5 years based on these trials, but we still don't have any way of selecting who these patients are at the end of the day. We still don't know somebody who comes to our clinic today, are they going to be in that 24% that are alive at 5 years? So I think we sort of dropped the ball on the biomarker development and trying to figure out how best select these patients. So we're exposing a wide population to toxic drugs with the hope of having that 24% 5-year survival. And yes, that's good to see. And maybe having 10-year survival data would be encouraging, but it still doesn't solve the fundamental problem for you and I in the clinic and for the patients that we're sitting across, because we still don't know who these patients are who are going to have these long-term, survival. So I know this might be a little of a naive way of looking at this stuff, but I think if I have 10-year survival data with Pembro or Ipi/Nivo or something else, I'd say, hey, good, nice, but how am I going to use that in the clinic right now?
I think it's an
So
excellent point.
the one other thing that I just want to point out here about the problem about trying to wring as much data out of these tails of the curve. I mean, at some, in some first group, I think it's encouraging because maybe the patient who's diagnosed with lung cancer now can know there are 10-year survivors. That's an encouraging message. But the idea that it's going to be something that's going to differentiate one of these regimens from the other is hard. And I had to review this data from somebody and have been very familiar with all the PD-L1 less than 1% data and all of that. But interesting, if you look, the long-term data from Checkmate 9LA in cross-trial comparison looks worse in these PD-L1 negative patients than the 227 less than 1%. Now, does that mean that the chemo is hurting these less than 1% patients in that? Probably not. These are probably simply data quirks that we never designed the study this way to be looking at 4-5% absolute differences at 5 years. And what that means statistically is really unclear.
I think really good points. I mean, I am going to ask actually, because, part of the discussion about the significance here, it really kind of focuses on some selection and kind of how do we select the patients. I may ask actually, both for the original pembrolizumab studies and for, some of these studies, whether it be 9LA or Checkmate 227, what investment is there that has gone into trying to isolate the biomarkers for these longer term patients? Have the companies been pushed enough to kind of really say, what are unique about these patients? Any other analysis there for these long term patients, whether it be pembrolizumab or, IO combination or such?
I can tell you that we always have discussions with the sponsors when we're part of these studies and we're on the steering committee to share the data, to do the biomarker work. And again, I'm more familiar with the Nivo and Ipi-Nivo type of story. And yeah, there are going to be some publications and presentations and all that regarding some potential biomarkers that have been looked at. Obviously, if there was something really earth-shattering, you would have heard about it by now. But you're driving at another fundamental sort of issue. We just had another meeting in New York that Dr. Fred Hirsch puts together as the second one that sort of talks about what's wrong in the world of lung cancer. It's not a data discussion type of a meeting, but it's sort of where we're going with lung cancer, what's missing. And that was sort of highlighted. And I can tell you this was a very open discussion between academicians and industry. We, on the academic side, always blame pharma for not sharing tumor data, not sharing biomarker data, or being very particular as to the data that they parse out. At the same time, the pharma companies came back and said, every one of them that was at the meeting saying that, well, we have clear guidelines, once the study is done on CSR, the clinical report is submitted, the data becomes available. Our investigators get first dib as to what we should do and what they want to do. And then the data becomes available by request to all the other investigators in the world, which, for you and I basically means if we're not part of the study, it might be 7 or 10 years after the trial before we get access to anything. But they sort of say they have those kinds of policies, and you do see it from time to time. But it is only after the full clinical data set has been publicized and published and all of that kind of stuff. But at the same time, industry came back and said, well, you guys keep saying we want biomarkers and we want this and that, but when we do a phase 2 or a phase 3 study, we only get 15% tumor samples at progression, and we only get 10 blood samples and at progression. And so you guys keep saying you want biomarkers, but you don't do the work to collect the samples so we can have the data set to talk about. So again, it was a nice discussion to hear back and forth from their point of view, and they definitely have heard it from our point of view. I still think we can do a better job of asking our colleagues in industry to be a little bit more forthcoming. But I also see the point from their perspective that if we really, really are so gung-ho about it, why are we doing such a lousy job collecting samples or talking to our patients about giving us additional biopsies? Hey, the bottom line is it's really hard to be sitting across a patient who just has had some disease progression on a trial and say, hey, thank you for participating. This is brave of you. We really appreciate it. By the way, before you go, I want to do another chunk of your tumor so I can figure out why the drug didn't work. So I think we have a little bit of a difficulty in that, which is understandable. But there isn't a good repository of all of this data for everybody to have access to. And I think that's unfair. I think we should make the data available a little bit more widely. When you and I now publish, every major journal, I was just reviewing something for Nature. I mean, the amount of work that goes into releasing all the algorithms, all the website that they use, everything that you have done, all the RNA-seq data, all of the DNA genome, you have to publicly make that available pretty much without a lot of restriction. So if we have to do that, I think we're going to have some sort of a rule for the pharmaceutical companies to also do the same in a timely fashion. Again, it doesn't help us 10 years from now to have data from 227 saying this biomarker versus that, and it didn't work. We kind of want it more quickly. And I'm not sure I know of a mechanism that gives us access to that. I'm sorry, this was a long-winded answer to your
No, but I
question.
think it was great. No, I think it was great. And Eddie, any thoughts there with pembrolizumab or kind of the work that you've been part of?
No, the only thing that I think is important is to remember because you have one of the things, obviously from the pembrolizumab program was the PD-L1 biomarker. And at the time, everyone sort of poo-pooed it. But I think there's one aspect about it that people sort of lose in sort of how it was a helpful marker which was that you weren't looking at 40 different things and you weren't trying to calculate a gene expression score and trying to incorporate a whole bunch of things. It was a really straightforward hypothesis, right? The more PD-L1 you have in the tumor, the more likely you're going to have an effect of the drug. And conceptually, it's at least partly right. And so that was the thing. I think one of the things is you start getting these very complex biomarkers that people look at, and it can become really difficult I can imagine for somebody who I mean, my federal funding is in biomarkers for immunotherapy. This is obviously something that I consider myself an expert in. But I think that if you're just in clinic, whether somebody's giving you a set of biomarkers because they think it's going to give them a competitive advantage versus the idea that it's some biological truth, I think would be extraordinarily difficult for someone who's seeing patients most of the time to evaluate.
Yeah, really good points actually, and I think really I miss, Haas, it would have been great to be part of that meeting as well with the larger questions. I'm
Yeah,
just going to kind of round this out actually just in the last.
Hadam, do you mind if I ask a question? Hi, this is
Yeah, no,
Ashkan.
please, Ashkan. Yeah.
This discussion has been fantastic because I think so many of us, speaking for someone who, sees not just lung cancer, but a little bit of everything, dealing with the nuances of lung cancer has become very challenging. And when we're looking at just immunotherapy alone, with or without chemotherapy, I mean, certainly it brings on more challenges. And I think you guys have just discussed great points. I think the issue regarding, what's in the sauce with CTLA-4 is huge because we get constantly bombarded by reps or other people saying, "Oh, are you using this regimen? Why not?" And all of the, and everything, all the points that you've brought up really don't identify a clear, selection of who these patients are. It's kind of like, well, as Huss said earlier, well, I provide, maybe the squamous with the PD-L1 low or absent. It's, and of course, there's some, data to support that, but of course, a lot of this is not all that clear. I guess my question to you guys is, how do you approach your patients? Is it really a shared conversation between you and the patient? I will tell you that that's generally how I approach things. I think certainly adding in a CTLA-4 antibody is something that I do for those who are perhaps younger, PD-L1 low or absent, and need a response quickly. But I certainly can't identify who these patients are in terms of who will have a long-term, remission or stability of disease. And for that matter, I mean, I think all of us have probably had patients based on the 1 to 49 checkmate. What is that? The 041 or 042, which showed that, there are some patients who do quite well on single agent Pembro and can have long-term stability of their disease there. I mean, I just wanted to get kind of your opinions on how you guys approach this in the clinic.
Ashkan, that's a really difficult question and a good one, right? So I have said this on the podium, and I say to my patients every time I have to make a selection, I would tell them that I have a personal bias towards an IO regimen. I believe that CTLA-4 works better in this particular patient population with PD-L1 negative squamous histology or KEAP1. And I let them know that I was an investigator on an IO study, and all of that goes into my bias towards looking at the data. I would also tell them that if they had PD-L1, 30%, I would not have offered them a CTLA-4. I would have gone with chemo IO. So I do spend a lot of time trying to go over all of this. And to be honest with you, if I have somebody who is for better or worse, a little bit on the older side, a little bit poorer performance status, a large burden of disease where I really think I need some cytotoxic action from chemotherapy, I don't use it. And I explained that. But that goes back to again, some of the discussions that Eddie and I have had. I think we're all suffering from the fact that we can't select the patients who are going to have the most benefit because we don't have the biomarkers, and none of the clinical features that we've looked at really is all that predictive. So I do exactly what you just said. I talk to the patients and I say, hey, this is the way I look at the data, and this is what I'm offering you, but it comes at more toxicity, and we sort of go based on that.
And I will tell you, I personally think that this sort of shared decision-making term in general is sort of, it's a buzzword and it sounds great, but the reality of it is something a little bit different, right? So if you asked Haas and I whether we employ shared decision-making, we would both certainly say yes. And we talk with our patients about many different approaches. But there are many situations where almost all of Haas's patients probably get a dual IO regimen, and the great majority of my patients do not. And it's not that either one of us isn't performing sort of shared decision making. We just have different inputs in how we explain to them what the pluses and the minuses of these things are, because those are legitimate differences in a murky area that we have. So I do try to often explain to my patients, these are the choices. Here are ones, this one, some people might do this, but I think this is ridiculous. I don't think this makes any sense. Here are things, and if you had to make me choose, I'm 60-40 one of them. And then sometimes in those situations, they do choose the 40, particularly if it's less toxic or has some other benefit to them. So we do have that, but it always is sort of a funny idea to me, because in the end, of course, we all bias our patients, and that's why they're coming to us, right? Because they want our expertise, although they sometimes are going to differ among people who do this all the time and think about it extensively.
I think this is excellent, partly because it just highlights actually the fact that, unfortunately, in the clinic, we are working with some element of limited data, and we're seeing things through the lens that we see that. I had brought up the Poseidon mutational analysis, just to say that, I think that's, perhaps, kind of one strategy is to kind of say, how do we better refine the patient population to know who to address with the CTLA-4 combination? But we'll see how that plans out in the Triton study, the prospective study. In the last few minutes, actually, I just wanted to kind of talk about forward directions of kind of where, some of the trials have headed, and just to get your candid views on some of these points. So here are ongoing trials looking at ADCs plus PD-1. I may just take like a few seconds or a few minutes to kind of say, Huss, what do you think about the strategy of ADC plus PD-1? Do you feel like this is a viable strategy? Do you think this is just going to be kind of similar to chemo and not really something unique or different? Is there a concept of an immunogenic cell death process here?
Well, doesn't matter what I think about it or not. The studies are ongoing, so people didn't ask me clearly. So, but again, in all transparency, I do have the AZ studies of DataDX with Dorva and all that. So here are my couple of fundamental concerns. One, we're trying to replace a very well-tolerated chemo, pemetrexed, in many of these regimens, and replace it with something that's clearly more toxic than pemetrexed. I think that's a little of a problem. So right there, the ADC combination must have a significantly better clinical outcome for me to say I'm not going to use pemetrexed, I'm going to use a more toxic drug in Dato-DX to sort of justify the toxicity. So the clinical activity has to be far better than what we were getting with pemetrexed, in my view. Again, pemetrexed is one of the best tolerated chemos around, and we're trying to just replace it. I think we should get away a little bit from this immunogenic cell death story. I think there's some recent data, and don't quote me on this, but I think it was Charlie Swanton's lab sort of saying that really doesn't really happen all that often with chemotherapy. There could be other labs that have also looked at it. I think chemotherapy helps in that it has cytotoxic effect. It has some additive activity with some of the checkpoint inhibitors and prevents that early progression. But long term, it could have some detrimental effect on some of the other immune components that we want to see. So I don't necessarily buy into this whole idea of ADCs causing more immunogenic cell death. I could be wrong, but that's the way I look at it. So the strategies are ongoing. And as you see, this study has 975 patients. We're going to know sooner or later whether this is a viable option to take patients through or not, and whether it's worth the effort. And you know, replacing the better tolerated chemo in a platinum doublet, again, to me, only works if the clinical activity is significantly better. I think Dato is a reasonable ADC, but it has some toxicities that are very similar to some of the other chemotherapy drugs in terms of alopecia and, you know, cytopenias and issues like that. And again, the secret sauce, as Ashkan calls it, is that the clinical activity has to match the toxicity.
Thank you. I mean, Eddie, any thoughts there on this too?
No, just when you asked the question, it reminded me sort of years ago. There was a study I remember of the drug. Somehow it was supposed to flip in the membrane, one of the lipids that tends to be on the inner portion of the membrane to the outer portion of the membrane. It never really fit very well into a mechanism, so nobody knew what to call it. And then the immunotherapy drug started to have success, and then all of a sudden it was an immunotherapy trial. And I couldn't rule out that moving one lipid from the inner membrane to the outer membrane was an immunotherapy, but it didn't really strike me that that would be that meaningful from an immunotherapy perspective. This sort of gets into the same thing. The similar buzzwords now are that it's a modulator of the tumor microenvironment, or it's leading to immunologic cell death. And these to me are things I can't rule out, but I also don't have high levels of confidence that they're happening in biologically meaningful ways.
No, thank you. So I think we're just going to have one last question now, which is, you know, we've heard a lot about multiple checkpoints, even heard about the concept of bispecifics, which conjugate, you know, different strategies against multiple checkpoints. You know, Hus, where are we at with other checkpoints apart from CTLA-4 or PD-1? You know, are you seeing any kind of ones that are rising to the surface, things that we should be more aware of than others?
In the data leaks. Sorry for those. Yeah, sorry about
That's okay. No, I unfortunately don't. That goes back to the very first thing that you showed, that the very first algorithm, and I think Eddie said it and I echoed that it's been disappointing that we haven't had anything. I don't see anything rising to the level of being really important. However, I would justify that by saying I am super excited about bispecific antibodies. The more data I see with them, the more hopeful I get that some of these are going to rise up and be a real contender in the space, because there's more data. Just a couple of days ago, I saw data for another bispecific where the binding to one target increased the affinity of the second head of the antibody to the other target 8-fold, and had this significant inhibitory effect. And that was like amazing to see, which is, and again, there've been a couple of clinical trials actually doing this. So giving two antibodies was less effective and more toxic than using a bispecific that targeted both of those. So I think there's something magical about the way bispecifics can bring two tumor antigens, or if you want to go with bites, one tumor antigen, one immune antigen together, and kind of make the tumor microenvironment, for lack of a better word, a little bit more permissive to the effects of the antibody. So I am excited about the bispecifics. Now, which one is really going to be the one to go forwards, I don't know. But your question of whether like a TIGIT or an OX40 or a BB1 or any of the other for you know what I want to say, one of the other ones are rising to the level of sort of being competitive. I haven't seen any data like that.
So, well, Eddie, you have the last words. Any thoughts from your perspective here on that question?
I don't have a lot of expertise on some of these newer biospecifics, but the one thing that I will say is that I'm at least more open to them, because if you would have asked me, is it, how effective would it be to combine an antibody against EGFR and MET? And I said, well, it's not going to be a particularly, you could get, I can't rule out that you get approval, but why is that going to be better? And my personal bias is that they're going back and now trying to figure out the science on a drug that frankly worked better than people thought it might. And so why it worked better than they thought it might and how far that extends, it's hard for me to know. And so I do think it's certainly worthy of additional exploration.
Thank you both. I think, just the last concept we were going to talk about was TILs, and, there's an improved therapy now in melanoma, so we'll see how that shapes up in lung. But thank you both for your, really insightful review here and comments. And Ashkan, I'll let you close out the
Yeah,
meeting.
no, thank you. Wonderful discussion with everyone. We really appreciate you guys spending time with us, always learning. I think we're always learning a great deal. And I think the beauty of this conversation is that there's more to discuss as more information becomes available. So thank you so much once again to Hatem Husain to moderate this great session. And Dr. Borghaei and Dr. Garon, thank you so much for your efforts. And we'll see you guys soon. Thank you.
Thank you, guys.
Everyone, take care. Bye-bye.